All right, this is our final symposium. We're going to discuss some controversies in posterior spine surgery, so we have some phenomenal speakers and should be entertaining. So we'll kick off this session with Dr. Mroz, who will discuss cervical foraminotomy, when and why.
Good morning, everyone. I was asked, obviously, to speak about posterior foraminotomy, the when, the why, and the how. I do have some disclosures, but none of them are relevant to today's talk. From my perspective, I do only cervical surgery. Well, I do some lumbar surgery for patients that I've treated in the past, but for cervical radiculopathy, I probably treat them, 60% or so with a posterior foraminotomy because I just think it works. But the indications, from my perspective, are anybody with the cervical radiculopathy, and it could be a young patient or an old patient, soft disc herniation, or the disc osteophyte complex that we see, and obviously any age, I think, is an indication with some caveat. The results, in my opinion, are pretty consistently favorable across the peer-reviewed medical literature. If we have any literature on a topic in spine surgery, it is on cervical radiculopathy. Contraindications in patients who have true axial neck pain that predates the clinical syndrome with which they're presenting. So if a patient has a 4-year history of axial neck pain, but they only have a 2-month history of a radiculopathy, it's typically not a patient. Keeping in mind that patients who have a radiculopathy most commonly will say they have neck pain, but it's traditionally off to the paraspinal musculature, oftentimes at the cervical thoracic junction, and that could be determined with a selective nerve root block. Instability, so a small degree of spondylolisthesis, at least in my opinion, is not an indication for surgery. It's a contraindication. And any patient who has asymptomatic stenosis in the setting of a cervical radiculopathy, I typically do not treat those patients with a posterior foraminotomy. Those patients will either get a TDR or an anterior cervical fusion. Some of the facts about cervical radiculopathy, because I think there's still, in 2024, and I don't know why this is so, there's still some debate about the merits or limitations of foraminotomy, but it does cause more acute neck pain in the postoperative setting. There is a higher risk of infection, 2% versus less than 1%. It requires a microsurgical skill set. The merits, though, I think we don't have to deal with non-union. It does preserve motion. There's no anterior morbidity. It's just as good as an ACDF, which I'll show in a few moments. There's no instrumentation, and it is certainly cheaper. On the flip side, though, you get paid probably a third of what you would get paid for an ACDF. The myths, the things that are untrue. It does not cause chronic neck pain. It has a higher failure rate at the index level versus ACDF. There is a higher rate of neurological injury. Only neurosurgeons do them. And it can only be done for soft discs. I think all of those things are false. When we look at the comparative data for a PCF versus an ACDF, I think that we can say when we look at the peer-reviewed medical literature, it's equally efficacious. This is a randomized controlled trial done by Rudin. Now, this is endoscopic posterior foraminotomy, and they found, looking at validated outcome measures, VAS, arm, neck, and a variety of different other outcome measures, that ACDF and PCF were equally efficacious. Another study published in, I think this was JBJS in 2017, looking at ACDF versus PCF, found no difference in complication rates, clinical outcome, or reoperation at 2 years. And then we have to ask ourselves, is there a higher failure rate? Because many people who are opponents of cervical foraminotomy will say, well, there's a higher failure rate. These patients just don't do as well, and you have to reoperate on them, which means that you would come in and do an ACDF. So we wanted to look at that, and there's no difference between an ACDF and a PCF. This is a study that we did at the Cleveland Clinic, just a simple retrospective analysis involving 178 patients, and we've determined that there was a 5% revision rate to ACDF and index level, and this was similar for ACDFs. I don't care how good you are as a surgeon, not every single patient you do an ACDF on is going to get a union, and not every single patient is going to get rid of their radiculopathy. The majority of them will, but it's never 100%. We then did a propensity matched cohort analysis combining our data with that of Dan Rue's data at WashU when he was there, and we found that with this propensity matched cohort, the reoperation rates, the absolute difference was 1.4%, but there was no statistically significant difference between the two cohorts, indicating that the rates of index surgery revision are similar. So when we look at going on to the how, posterior foraminotomy can be done from an open approach with a McCullough retractor or a black belt retractor, or with a tubular retractor. But the decompression is going to be similar. For an open approach, we just obviously make a midline incision, move the muscles aside. We all know this approach. We can also do it through a tube, which you start 1.5 centimeters from the midline, and dock your tube. Typically, a 16-millimeter tube will be sufficient to do this. I don't do this with a tube anymore. I think there's a risk to introducing the smaller tubes because these patients are placed in slight flexion in order to open up the interlaminar space, and so there's potentially risk for interlaminar breach with the smaller tube. But you can see the axis really doesn't matter. I don't think the incisions are going to be the same. Looking at this, this is inconsequential to the patient. Now, the way in which we do these, if there's ever a chip shot in spine surgery, this is definitely the surgery that is a chip shot. This is not my procedure. This is a procedure that I learned 18 years ago or so by Dan Rue, sitting when I was a young staff when he was giving an ICL. But what we do is we just make geometric cuts. And so what we want to be able to do is we want to be able to see this this area right here. This is a triangular confluence of the lamina. You've got the ligamentum flavum right here. We want to be able to cut all the way out in this vertical limb. This is the IAP. We're on the right side of the spine right now, and we want to be able to approximate the pedicle of the caudal level. If we decompress out to the pedicle, whether it's from the front or from the back, nothing lateral to the pedicle in a degenerative case is going to be compressive of that nerve root. And as you know, after the pedicle, the nerve root starts to track ventrally. So we make this cut with a high-speed burr, and we make this a strategic cut. So this is not a curvilinear cut. This is a right angle or so. Some morphological differences from patient to patient, but in general, it's a right angle. And then we remove that triangular piece of bone with a Roten 3 from the Rotan instrument tray and a micropituitary, and then we make a mirror image cut using, again, a burr. We'll see this in a video in a moment, and then we're left with a triangle, and then we remove that as well. And that's all this surgery is. There's no kerasins or anything of the sort. This is an example of a patient who had a disc herniation, the paracentral disc herniation involving the foramen. And what we did is, again, we make the blue image cut. This is Paul Shin, who's now an attending over at Harvard, actually in Penn, I'm sorry. And we make this, I'm sorry, it's not playing properly, but we do that cut on the inferior articular process out to the pedicle of, in this case, it's going to be C7. And then again, for just diagrammatic purposes, we just draw it out with a blue marking pen. And then we do the mirror image cut on the opposite side. In this case, it's the superior articular process, again, out to the pedicle, coming up to the lamina, which is, we want to do a laminoforaminotomy to allow some drift back of the lateral dura. And we'll give you a better view of what it looks like if we go after a disc. I don't think that every single foraminotomy, if you have a disc herniation, needs to include a discectomy. I think if the disc is inside the axilla of the spine, then it makes perfect sense to go after it, but I don't think you need to do it. And so what we were doing at the end of that video is taking a small nerve hook from the Rotan instrument tray, feeling the pedicle. In this case, it was C7. And if you, again, if you can feel the pedicle, which in my opinion is the lighthouse of the decompression in the cervical spine, then the surgery is complete, and that's all you need to do. This is a different patient who had this is an interesting patient, actually. This is a patient who came to me, said she was going to sell her farm because her arm pain was so bad. Classic radiculopathy, but a gem of a human being. But she had a intraforaminal disc herniation. This was a soft disc herniation in a 50-ish-year-old woman, and very classic here where we see a very soft disc herniation here, classic radiculopathy of C6. And this is the patient that we did through a tube, again, left side. And this is the pedicle. So the foraminotomy has already been done. I switch over to a diamond tip burr just because I want to be a little bit more careful. You want to irrigate that because it does heat up. You don't want to give a thermal injury to the nerve root or the lateral dura. We then resect the ligamentum flavum right here and some of the capsular stuff overlying the nerve root. And this is where I think you have to have a microsurgical skill set, familiar with the micro scissors, et cetera, et cetera. But what we see here is the nerve root of C7, right, C7, and then the lateral dura. I do expose the lateral dura, and I think that's important because sometimes when you have a subligament or a subannular disc herniation, it can be very confusing about what's dura and what's annular of the disc. And so, I learned that from my neurosurgery partner, Ian Kalfas, and I was lost. This is probably 10 years ago. I mean, I cannot figure out what I'm looking at here. And he said, just expose the lateral dura, which I did. And every time since then, I've always exposed the lateral dura, and it clearly sees where you can clearly see what the nerve root is and where it's taking off in the lateral dura. But it makes detection of the nerve, of the disc much more easier. And so you can see through this small approach, working in the axilla, you can get multiple fragments of disc. But again, I don't think necessarily you have to go after the disc in every single foraminotomy that you do. And this is just a setup, and again, I'm not advocating for a tubular thing. This is earlier on in my career, and I don't necessarily do this at current time. So in conclusions, I always get asked, well, if it was you, would you have a posterior foraminotomy? And absolutely. So if I had a foraminotomy, whether I was in my 30s, 40s, or 50s, or even 60s or 70s for that matter, and my spine, I did not have any instability, I didn't have chronic neck pain, and by hands down, I would find somebody who can do a foraminotomy and have a foraminotomy done. Not that I'm down on fusions, but I think if it's a simpler procedure, it's cheaper, and it's equally efficacious with a safety profile that is like an anterior approach, I'd probably go definitely with a PCF. But thanks so much.
All right, we're open up for questions. Those were all excellent talks. Thank you, guys. And thanks to Barrett for organizing them. So questions? Dr. Patel.
Great. Yeah, thank you again for everybody. Fantastic symposium. It's probably a question for the whole panel. Was around wound closure, the topic around wound closure, and we talked about some good adjunctive techniques. Has anybody changed their actual closure? Many of us know Dan Rue is one of our former CSRS presidents and talks a lot about the closure technique being really important. So what do we do with closure? Types of suture, layers of closure?
So I'm not one of his fellows, but I've had fellows who have been his trainees. So I now pretty routinely will put, not in 3 muscular layers, but certainly some kind of small bite, just 1 ovicral sutures for the muscle. I mean, it's undeniable. The nuchal ligament has to be perfectly reapproximate. If you miss that, that wound's going to splay. So for us, we use, obviously, deep drains. I told you we do betadine and vancomycin. Then muscle approximation, numerous small bites, just to approximate it. You don't want to necrose the tissue, obviously. Not necessarily a layered muscular closure, but muscle, nuchal ligament. If they're really big, they get a superficial drain too. And then closure with an IVAC.
Dan, you want to comment?
Yeah, nothing to add. I agree. Some people are looking at permanent sutures in some of these nuchal ligaments, so you avoid the popping of that suture 1 month out and then the splaying. I'd also argue, just to throw in the measurement stuff, if you end up closing it when it is kyphotic, that is a higher risk. So understand that if you're stuck, but if you can get that patient back, seeing that nuchal, all those ligaments come together is much nicer versus it being under tension as you close.
Yeah, I love the idea of a mesh suture. Maybe Gabriel, I can ask you as well. When I've had a chance to visit the CSRS AP meeting, there's a lot of talk that we don't have here around muscle sparing or muscle preserving approaches to the posterior cervical spine. Can you give us just a little bit of insight on how that might help solve some problems we talked about today?
Yeah, thank you very much. And then, as you know, in Asia, I mean, we are going through a kind of a revolution at the moment, and then there's a lot of endoscopic surgeons coming up, so they will try everything endoscopic. Some even tried, there was one case that they have an odontoid mass, they tried to do endoscopic from posterior to go to in front to reduce the endoscopic. So we are still trying to sift through the information, but in general, yeah, for wound closure, I mean, I would do exactly the same as what you guys have talked about. I visited Dan a long time ago, and I still use 4 or 5 layers closure. And one of the things to highlight in the wound closure is that probably the wound closure starts at the beginning and you do the dissection. Right at the beginning, if you don't get the right plane to start with, you can't close it properly in the beginning. Going back to the question in terms of wound and endoscopy, they are now trying to do endoscopy foraminotomy, which I understand, but they are trying to do endoscopy laminoplasty, which I'm trying to understand, and then the only problem that we face in endoscopy in cervical spine, nobody really talks so much about it, but there's some whispering, is the fluid pressure, and then that.
I want to thank Barrett again for organizing it and all the panels. Those were excellent talks. Thank you guys very much.